Conference record has joined the conference.
Good morning, everybody. We're just about to get started. We're going to wait a minute or two more before we introduce today's guest, Dr. Barry Sarvet of the Massachusetts Child Psychiatry Access Project, which is an innovative approach in Massachusetts to extending the professional work role of child psychiatrists. All right, so let me just get started by introducing our guest. Dr. Barry Sarvet is the Chief of Child Psychiatry and the Vice Chair of the Department of Psychiatry at Bay State Medical Center in Springfield, Massachusetts. And he's also on the faculty as an Associate Clinical Professor of Psychiatry at Tufts University School of Medicine. How I've come to know Dr. Sarvet is through his leadership on a very creative program which has provided access to child psychiatry, which is in short supply in Massachusetts, and it turns out everywhere else in the nation, to strengthen the capacity of pediatricians across the Commonwealth to help children with psychiatric assessment and their care planning. Dr. Sarvet, I want to thank you for donating your time to NAMI, and we look forward to learning from you. And after you give your remarks, we invite our listeners to ask a few questions. And thanks again. So take it away, Dr. Sarvet.
Oh, thank you so much for the introduction and the invitation, Ken, and thanks so much for having me on the call. So I think I'll get started by telling you that this project that Ken mentioned, the Massachusetts Child Psychiatry Access Project, has been going on for about coming on 10 years, actually. And it started on the base. Actually, it was instigated by a real kind of ground spring of advocacy work by consumers and doctors and parents and all kinds of people from the community from all different walks of life, who were really increasingly concerned with the difficulty in terms of trying to get mental health services for kids. And I actually think that Dr. Duckworth may have been involved in a study that was actually done by the Parent Professional Advocacy League. And this was done in 2002, a couple of years prior to the beginning of our program. And it was a parent survey. It was entitled "The Experience of Massachusetts Families in Obtaining Mental Health Care for Their Children." And some of the findings of the study were that 33% of parents had to wait more than a year for an appointment with a children's mental health provider for their child. 50% of the parents reported that the pediatrician never asked them about their children's mental health, and 77% reported that the pediatrician was not able to be helpful in connecting their kids to resources. And so there are lots of other findings as well, but I picked out those because it's the most relevant to the solution that we came up with. That we've decided among a group of advocates and people who are involved in planning that one of the best ways to help kids to get early recognition and to help them get services before the mental health problems progress to a severe level was to work with pediatricians, or not only pediatricians, but to work with pediatric primary care providers, and to consider pediatric primary care providers to be the kind of army or the soldiers, on the ground, trying to kind of address and to be able to respond to mental health needs early. So pediatricians and pediatric primary care providers are seeing kids. Most kids end up getting some well child care. In fact, actually, most kids actually get routine well child care. It drops off in the teenage years, but almost everybody actually has access to pediatric primary care. and people are bringing their kids to the pediatrician's office to get checkups. And one of the problems is that the pediatricians actually don't have much training in mental health, in children's mental health, and they feel very kind of cut off and disconnected from the mental health system as a whole. And so they, are insecure about being able to do this kind of work, but they're in the perfect position to do it because they're seeing the kids, and they also have a good, trusted relationship with families and parents, and so generally, most parents feel relatively comfortable sharing with pediatricians, their worries, and concerns about kids, which is actually not always the case for schools. Another strategy for trying to reach kids who have mental health needs is through schools, and I think that's a very worthwhile strategy. But there is a barrier in the sense that a lot of times parents are worried about kind of disclosing their deep worries and heartfelt worries to schools about their kids' mental health because they're afraid that the kids are going to be kind of tracked differently, and they're afraid that they're going to be judged, as parents and blamed, and so it's not quite the same with pediatricians. So we feel that the pediatricians might be really well positioned to be the first responders, so to speak, to the early presentations of mental health problems. So we actually wanted to address those two problems in utilizing that strategy. The first problem being the fact that pediatricians don't have much training in mental health and psychiatry. And the second problem is that the pediatricians aren't really connected. They're not plugged in to the whole community and system of mental health services. And so we created this program. We've been doing it for about 10 years. We were fortunate to be able to convince the legislature to fund it out of the state budget. And so the program set up 6 teams of mental health experts around the state of Massachusetts, and there was one team in each region. We sort of divided the state into 6 regions, and we set up a team in each region, and the team for each region was charged with developing affiliations and collaborative relationships with every pediatric primary care provider in the region. And so each region has about 250,000 children on the basis of population, and each region has about 200 to 250 primary care providers as well. And so there's a lot of sort of social networking and professional networking that the teams had to do to establish these relationships with all the pediatricians. And then once those relationships were established, the teams were sort of tasked with offering them a variety of services. So here are the services. The first service which the teams provided is a hotline to the pediatricians to answer any kind of question or to try to address any need that the primary care practice had in relation to mental health services and trying to figure out, what to do for kids who are presenting with mental health issues. And so that hotline, was provided by each of the teams. So there's a separate hotline in each region, and we encourage the pediatric primary care providers to call. And when they call the hotline, they can get immediate telephone consultation with a child psychiatrist, actually, or with a therapist who's an expert in working in therapy with kids, or they could actually have an immediate conversation with a care coordinator who's an expert at finding services for kids. So those telephone consultations are an important part of the program. They account for about 3/4 of the work of the project. So we're trying to create this kind of net of sort of availability and connection to all of the pediatricians, and we try to sort of be there almost like a virtual presence in their practice through the hotline. So we try to make the hotline such that they can very quickly and easily get through to someone who can help them. So that kind of creates the connection with the mental health system, and it also, those telephone consultations are a vehicle for us to teach the primary care providers about mental health. So we kind of consider it to be kind of patient-based education. So whenever they see a patient that is coming up with a certain kind of problem, it's an opportunity to be a teachable moment for the pediatrician to learn about what to do and to how to understand, how to assess, how to sort out what the mental health problems are, and then how to develop treatment plans based on evidence-based practices and best practice recommendations that have been really discovered to be the most effective for kids. So those consults are creating that connection and also providing them with education. Many times, about a quarter of the time, when we have questions from pediatricians, we decide that we want to actually see the patient. So the next service, in addition to the hotline and all the consultations provided through the telephone, is that we have this rapid access evaluation program. And so you can get to see, so any kid who needs a psychiatric evaluation can get a psychiatric evaluation within 2 weeks through this mechanism, which is a remarkable difference from the usual kind of conventional practice where people have to wait months, and with that survey I mentioned, people have to wait sometimes over a year for the first appointment to try to address a need. So we designed our system so that we could do these consults right away. I guess the thing that we don't do and that makes it possible for us to have such a quick kind of rapid access to the consultation is that we're not actually keeping the patient. So we're not kind of taking the referral and then continuing to provide care for the patient. So that allows us to do many more of these consultations. And so what we're doing in the consultations is that we're trying to help to advise the pediatrician and guide the pediatrician in doing some of the work in the primary care setting to address the mental health needs. And then we're also trying to identify which kids actually need to have a child psychiatrist as their doctor treating them. So we're not saying that all kids should be managed by their pediatrician for mental health problems, but we're saying that some of them can be managed by the pediatrician. And so in the consultation, sometimes we're trying to identify whether or not it's really necessary for the child to have a specialist. Sometimes it's based on the preferences of parents, but it's often based on the complexity and the dangerousness and the risk involved in the mental health problem. So if you have a child who has a very common and not terribly severe mental health problem, such as ADHD or anxiety and sometimes with depression, then the pediatrician can actually provide the treatment, particularly the medical parts of the treatment, as well as the care planning and the coordination of the care with the therapist, without it having to necessarily go to a child psychiatrist. And it's all predicated on the basis of the fact that child psychiatrists are very few, that is a very scarce resource, and we want to make sure that we keep the child psychiatrists available to see the most complicated kids who have the most severe mental health problems. So we are doing some what we call triage in this process to try to kind of direct the patients who are the most kind of needing of child psychiatrists to the child psychiatrists, and then for pediatricians to be our partners and to collaborate with us in caring for the kids in the mental health setting for whom the problem is not as severe. So that's kind of the way the program works. We actually have, again, I mentioned that we've been doing it for 10 years, and so we've learned a lot along the way in providing the program. We actually have progressively been able to deepen our engagement with the primary care providers, and so we have very robust utilization of the program. So we actually currently have about 22,000 calls per year to our teams. So we are, doing a lot of consultation, and about 25% of those calls result in a face-to-face consult or an evaluation. And about half of the telephone calls are care coordination service finding calls, and the other half are consultation questions where we're helping to teach the pediatricians about mental health. The pediatricians are giving us feedback, and we've surveyed the pediatricians, and they've told us that they really like the program by and large. They find the consults useful. Over time, as they've used the program, the pediatricians have reported to us through surveys that they feel increasingly able to do the job of dealing and addressing mental health needs of kids, and they have more confidence in their ability to be effective in that. We actually have parent survey data. We just did a study recently where we surveyed parents whose children kind of were the subject of a call by the pediatrician. One of the first questions that we had in the survey was, do you know that your pediatrician called us about your child? Because we encourage the pediatricians to make sure that parents are informed of whenever they're talking about their kid with somebody. But we had no way of knowing for sure that they were doing that, and we found that in the vast majority of circumstances that the parents did know, and that they appreciated that the pediatrician was calling us. The other thing we asked is, how do parents feel about their pediatrician being a mental health provider? And the vast majority of people were comfortable with the pediatrician and really found that the pediatrician was very helpful and very supportive, knowledgeable, and culturally sensitive, and actually gave them adequate time to talk about their issue, which was very reassuring to us, because that was another, question that we had about, how this really is, going over with the people who are the recipients of the service. And so the survey, those were the main findings of our survey. Some of the parents were, when we surveyed them, were reporting that their kids were still not much better, and so we were not seeing a signal that the outcomes of the kids' well-being was significantly improved. But part of that was because we were surveying parents about a month after their initial call, and I think, as many of us know, it takes a while, oftentimes, for things to turn around when kids have behavioral health problems. I guess another finding of the study was that compared to other studies where pediatricians' referrals to mental health services like therapists were kind of successful only about 20% of the time. So there's some data that suggests that when a pediatrician makes a referral to a mental health provider, only about 25% of the time do they actually end up getting the service. And we actually were asked parents, so did your child get the service that the pediatrician was trying to arrange for you? Because we were making referrals to therapists and in many cases to child psychiatrists. And we had about an 80% success rate. A month after the telephone consult, the kids were actually had received a service that was recommended with the help of our care coordinator. So we're really happy with the way that parent survey kind of validated that some of the goals of our program were successful. I guess the last point that I would make is that since we've developed these teams, we're trying to leverage the system to try to address other needs as well. So for example, these teams actually create this infrastructure that really helps primary care docs to be more effective with mental health issues. And so we've actually utilized these relationships between the teams and the pediatricians to work on different kinds of goals, such as trying to help them to adopt best practice models. So we had a project a few years ago where we worked with several practices who were involved in the program to teach them how to follow-up protocol for screening, early identification, and management of adolescent depression in the primary care setting. So we consider this service to be an infrastructure that could allow us to work on quality improvement projects for pediatricians. Another thing that we've done over the years that we've really helped to support the practice of screening in the primary care setting. So the state of Massachusetts a number of years ago developed a policy that mandated pediatricians to offer mental health screening during all the well child visits to children from early childhood through transitional age, and actually, so our program actually, because we had these relationships, we provided a great deal of training to help the pediatricians to be successful in carrying out that policy. And I guess the last thing I will say, because I know I have to stop, is that we actually are starting a new spin-off project for our program. The program, Massachusetts Child Psychiatry Access Project, has the acronym MCPAP, MCPAP, and so we developed a new program called MCPAP for Moms. And actually, MCPAP for Moms is a program that's designed to try to address postpartum depression. So it's an adult mental health program that provides a similar style of consultation and care coordination, not just to pediatricians, but also to adult primary care providers and OBGYN doctors, as well as adult psychiatrists, to try to help to make them more effective in identifying and providing treatment planning for parents who experience depression in the postpartum period. And so postpartum depression is a major kind of mental health prevention issue that if we can help mothers and fathers actually feel better when their children are born and help them to address depression, which is a very common thing that occurs, that actually has the possibility of having a significant preventive effect in terms of preventing kids from having mental health problems. It also, addresses just the needs of those parents who are suffering oftentimes, and many times they're suffering without anyone recognizing the problem and providing them with care. So that's a spin-off project that we're doing, and it's starting in July, and we're looking forward to that. So I guess that's where I'll stop, and I know that there needs to be some time for discussion, and I'd be happy to entertain any questions.
Thank you, Dr. Sarvet. That was an excellent summary of a compelling public health model. Any questions for Dr. Sarvet?
This is Tanya, and I'm from Lansing, Michigan. And I just wonder how you get around the insurance, or do you? I mean, is there a problem with insurance paying for this?
Well, that's a great question. Well, first of all, the program is a public program, so it's fully funded by the government of Massachusetts, and the government pays for all the people who are providing all the services on these teams. We do bill insurance when we do the face-to-face evaluations, and we give the money that we collect for those face-to-face evaluations back to the state to offset, some of the money that the state has to pay. So the insurance is indirectly helping to pay for some of the consultation services. Those services only account for about 20% of the cost of the program. So most of the service is really publicly funded, and that's because most of the activity that we provide, most of the services we provide, are really not services that are kind of recognized by insurance companies. So insurance companies don't generally recognize telephone consultation and care coordination as a kind of a billable service. So that's an issue. We actually did succeed in Massachusetts to get some legislation passed that is levying a tax actually on the insurance companies in the state to help to pay for their share of the program. So starting this year, the insurance companies actually are contributing money to the state to help to pay for all of the telephone consultation that's going on and the care coordination. So that's actually a brand new development. And I guess finally, the insurance issues I think come up for us a lot around the care planning and the care coordination. So we always, whenever we help find services for patients, who are presenting in the primary care setting, we work with their insurance companies to get to find out who's on the network and to get authorization for the referral. And so some of the insurance companies have good networks, and some of them have inadequate networks, and so the ones that have inadequate networks end up making it very difficult for us to find services for people. But by and large, actually, we're almost always successful in finding providers. But it certainly does depend in part upon how good the networks are for that particular insurance company in that particular town where the patient lives.
Mm-hmm. Thank you.
Dr. Sarvet, on that question, do you know if there's any other Medicaids that across the country that are looking at starting this program? Because this program started as Medicaid, and then the commercial plans were brought into the equation. Do you have a sense of that?
Well, you know what, Dr. Duckworth, the program in Massachusetts from the very beginning was kind of across all payers. It was always publicly funded, not Medicaid per se though, because the program is funded through the state's general fund. So it's pretty much taxpayer funded at the state level, and it's not Medicaid, which is federal matching dollars.
Right.
And so we've never actually been kind of had a Medicaid waiver or really had limited our services to Medicaid recipients. Now, there are some other states that have. I should mention that the program that I'm describing has been replicated in many other states around the country, and we have a consortium of states that are involved in developing or actually operating these programs. We have 31 states that are involved in the consortium at this point. I would say about 10 of them have sort of fully functioning programs. Several of those programs are Medicaid funded. There's a program in Washington State which is Medicaid funded, and they actually serve Wyoming and Alaska, as well. And so that particular program is fully Medicaid funded, and they do telephone consultation for everyone, but they don't see the patients for face-to-face unless they have Medicaid. So they have to kind of make those kinds of restrictions. They also have a model where they're funded by Medicaid, and one of the functions that they have is that they have to do some medication utilization review. So they're basically doing some they're sort of doing authorization consultations with doctors who are trying to prescribe antipsychotic medications with the goal of trying to reduce the use of antipsychotic medications in children. And so that's actually saving the state a lot of money, and that's helping to fund the program in that particular state.
Is there a place that people could get information on the 30-plus state consortium? Is there a website or a resource that people can turn to understand what's happening in their state?
Absolutely. So we have this organization which is called the National Network of Child Psychiatry Access Programs, and we have a website which is www.nncpap.org, and we actually just we had a technical problem on the website, and so there is currently at the moment a kind of a I guess what's the word sort of a under construction page when you go to that
a placeholder, right?
Yeah, exactly. But it actually will be back up probably within the next 2 weeks, and it has a database actually on the website of all the states that are involved in these programs and what they're doing. So yeah, that would be a good thing to kind of file away and to go there.
We'll link that to the recording of this call. So
okay.
Some people can't do the call during the middle of the day on a Friday, but many people do access these calls on off hours, and so we'll be sure to link to that for the recording.
Great. Another website that you might put up there is that we have a website for our Massachusetts program at www.mcpap.org, and that actually website is it has general information about the program, and it's also utilized as kind of a educational resource for pediatricians. But it has a lot of information I think that would be helpful to parents and consumers as well, because it has a lot of parent handouts on common mental health conditions and also information about best practice recommendations for different mental health problems.
Excellent. So those are great resources for the NAMI members. Another question for Dr. Barry Sarvet. So hearing none, I'll jump in. I'm interested in how the child psychiatrists experience this from a professional development point of view, and also about their anxieties, if any, about liability for this kind of project.
Sure. So this is a new thing for child psychiatrists, and I think it's a good point, a good thing to acknowledge. So in Massachusetts, when we first launched the program, we really did need to do a lot of work to try to prepare the child psychiatrists from the different institutions who were involved in the program for the work, because it was so different from their usual practice, and we also needed to address, concerns about liability. So child psychiatrists are accustomed to collaborating with people, but I think that child psychiatrists consider themselves to really have the special knowledge that allows them to treat mental health problems, and they feel that their training, gives them kind of the preparation that's really necessary for doing this kind of work. And so this is a whole new kind of frontier, the idea of, in some ways you might consider it to be task shifting, to say there aren't enough child psychiatrists and we need to teach other people how to do it, and we need to find ways of configuring ourselves and find ways of shifting our model of practice to actually helping and coaching and guiding other people in doing it, rather than just doing it ourselves and collaborating kind of by coordinating our work with others. So I guess the point is that child psychiatrists are very accustomed to coordinating their work with others, but they're not accustomed to kind of coaching other people who haven't had the training that they have to actually do the work. And so part of the preparation was really talking with child psychiatrists about the access issues and the workforce issues, which are, if you look at the arithmetic of how many child psychiatrists there are and how many children there are with mental health problems, it's very apparent that if you don't do anything to help other people to address these needs, then most of the kids with mental health problems are just not going to receive services. So making the rationale clear to child psychiatrists, I think, was a big part of it. And then training and developing some ways to support the professional development of child psychiatrists so that they could learn how to do this kind of consultation and collaboration was important too. So we're doing that internally in Massachusetts as part of the operation of the program. We have 6 teams. Each team is provided by an academic medical center in Massachusetts. So we have a total of about between 25 and 30 child psychiatrists at any given time in Massachusetts who are involved in the program. And so it's a relatively kind of limited number of people, and it's relatively straightforward for us to internally train and coach our own child psychiatrists. But with these national programs cropping up around the country, with the other states, it's becoming important for us to address this at the national level, and so that's one of the things that we're talking about a lot in the professional organization for child psychiatrists called the American Academy of Child and Adolescent Psychiatry, is that we're talking a lot about the development of training programs for child psychiatrists to try to prepare them for doing this kind of work and encourage them to do this kind of work. In regard to the liability issues, I guess the point that is relevant to this is that doctors get sued sometimes when things go wrong, and so if somebody isn't actually seeing the patient and giving a pediatrician some advice as to what to do with a patient, the concern might be is if something goes wrong and the pediatrician didn't tell you something that you needed to know, then could the child psychiatrist be sued, and the child psychiatrist wouldn't have any kind of ability to prevent those things from happening. So the whole idea that we're doing a kind of practice that sort of puts us in the position of not really being in control. So we're sort of advising, but we're not really in charge of the care. So when we do telephone consultation, we don't have the ability to get all the information that we might need. And so that's a very frequent question that comes up. And I guess the response to the question is that first and foremost, from a liability standpoint, that the fact that we're not in charge and they're not in control is actually it's what makes us nervous, but it's also what prevents us from being held responsible. That there's a tradition and a precedent in malpractice law that the doctor who is in charge of the decision is the one who is responsible for the decision. And so I think it's very clear that when we do telephone consultation that we don't have the authority to make any decisions, that we're giving the doctor who's caring for the patient information, and we're certainly responsible for the accuracy of the information that we give, but we're not actually making the decision. That decision is in the hands of the doctor who's caring for the patient. And I guess the other thing is that we consider what we do to be an educational service as opposed to kind of a treatment service. So we're basically telling pediatricians about medications that are considered to be effective for particular disorders. We're telling pediatricians about what are the guidelines for making a diagnosis? What are the criteria for a diagnosis, and how do you evaluate patients with a presenting problem? And so things like that, that kind of practice is not, again, construed as actually patient care, that we don't have a doctor-patient relationship. And so those things actually result in a limitation in liability, although there's never an absolute limitation in that respect.
Thank you. That's a comprehensive answer, because it's a complex issue, because you're not only trying to change the way people think about using child psychiatrists, you're actually trying to change the culture of both the payers and the child psychiatrists to think about, joining this program. Does anyone else have another question for Dr. Barry Sarvet?
A quiet group today. How many people do we have on the line? Do you know?
I haven't heard a lot of beeps. This could be more of a graduation and luck phenomena.
Oh.
The luck of the draw of when the calls are does drive our attendance from higher to lower, right. And it's really hard to predict. So we've had calls with 2 people and 2 calls with 200 people. I think we're probably on the low end because I haven't heard a lot of beeps.
Right.
Does anybody want to sing out who they are, where they're from, and if they have a question?
Well, I said I'm Tanya, and I'm from Lansing, Michigan, and I am the president of a small NAMI affiliation. I've got another question. If you
go ahead.
I had a man call yesterday. He's from a little town not too far from me, and he said he has a 15-year-old son that is bipolar and ADHD and something else I've never heard of. It's BIF, something to do with his intelligence. And so he said his son has a crisis situation, and they take him to a center, like a private hospital, and he stays there 30 days, and then they let him out, and nothing changes. They said he needs long-term care, and we can't get our doctor to say he needs long-term care, and they don't know where to go. They said we've talked to our insurance company, we've talked to the behavioral health center at the hospital, and he wanted to know if NAMI could give him some help. And I said I would see what I can find out. And it's like you were saying, there just aren't enough psychiatrists.
Well, in terms of the need for the long-term care, I don't know if they were implying that the child needs to be in a residential treatment. That would be a long-term program. I would be surprised. Maybe I shouldn't be surprised, but it would be a real injustice if this child was not discharged from the facility to some outpatient providers, and so I would consider the outpatient providers to be in a position and to have a responsibility to help kind of partner with the parents to advocate for kind of getting higher level services if they're needed. And I'm not sure about what's available in Michigan, but a lot of times kids with who might be considered to need residential care could benefit from kind of an enhanced team of community providers that could work together to really help a child to kind of to thrive in the community without having to be in an institution. But
right.
Those care plans are complicated, and they really require sort of the work of a program to sort of piece together all the different resources, so the family doesn't have to kind of just deal with just this patchwork of services with nobody coordinating it. So they need usually need some kind of care coordinator to try to help to pull together a team and to make sure each piece of the puzzle is being addressed in order to prevent kids from having to go into an institution. But yeah, that's a real complicated question, and I guess the first question I have is who are the outpatient providers that were kind of receiving the patient upon discharge from that facility?
Yeah, I'm not sure. He told me the name of it's in Saginaw.
Yeah. I don't know.
He said he's got really good insurance, and I know that if you go to community mental health, if you have insurance, they turn you away.
Yeah, that's one of the challenges of the system is that a lot of the services that are designed to really kind of meet the needs of kids who have severe and persistent mental illness are part of the public system of services, and they're not always covered through the commercial insurance plans. Mm-hmm. So that's a challenge. But
I would say the commercial insurer is responsible for getting you, your individual, mm-hmm. adequate providers to attend mm-hmm. to his needs. Now, understanding that there's a profound shortage of child psychiatry is one piece, but if they have a plan that, for instance, has a network with restricted number of providers, typically the insurance plans are written in such a way that if you can't use someone in the network, that the plan is responsible to pay for someone who's out of the network. And I think what Dr. Sarvet is saying is that somebody with training who knows this young man has to make the clinical determination about whether he in fact needs a long-term residential placement or if in fact he can be cared for at home, with services wrapped around him. You might know of the Rosie D. Decision here in the Commonwealth of Massachusetts. Dr. Sarvet and I are both from Massachusetts. He's on the western end and I'm on the eastern part. In our state, through Mass Health, the EPSDT lawsuit that became Rosie D. has created a series of wraparound services in the Mass Health, again in the Medicaid population. But what I notice is that commercial payers are starting to think about emulating that model. There's an increased interest in trying to see if you can meet people's needs in the community or working with the family to avoid things like long-term residential care. Do you know if that's happening in Michigan at all, where the state of Michigan's development is on this kind of alternative to simply, using deep-end services like residential or long-term hospitalization? Do you have a sense of that?
I don't think they are.
Okay. All right. Well, we periodically have calls on things like the Rosie D. Case here in Massachusetts. So, stay tuned to the Friday call because we really do try to cover everything under the sun. This is an area that some states are really emulating. But I would encourage this individual to talk to his insurer and find out if the insurer can access.
Yeah, that's what I told him. I said, call your insurance company and tell them what you need and just say that, it's not available through the community, through community mental health.
Right.
And so he said he would. He said he thinks that they only pay for short term. So I said I can't believe that.
Well, you'd have to understand how the Michigan system works. So residential programming could be paid for by the school district if he has an individual education plan. In some places, that's a school district payment structure. So I don't understand how the nuances. I grew up in Michigan, but at the time I wasn't attending to how their public mental health system and private mental health system was working. That was way back in the day, right? So I think that's kind of the key question is how does a school district, interface with this? How does the system of care, who pays for residential care in the state of Michigan? And is that a public responsibility? It commonly is, but it can be funded through school districts.
Okay.
So, I think he's going to have to, dig into this a little bit more and try to find somebody who can help him navigate the system.
Okay. I used to teach preschool handicapped kids, and I know a little bit about it, about that the schools would pay, say, to have a child go to a different school that's only for the visually impaired or, something like that. And I know they did that, but as a parent, you had to go in there, like Khrushchev and bang your shoe on the table before they'd listen. So, well,
it's important to remember people with psychiatric disabilities who are teenagers are the highest risk not to finish, to drop out of high school.
Right.
So this is a well-known phenomenon in the education world.
I'm keeping him at home. He said, I can't trust that he's going to go to school. And
right. So then that becomes a school. The school's an important piece of this equation. So the insurer's key, the public system is key if it works that way, and then, of course, the school is key. Dr. Sarvet, would you have anything else to add to that?
Thank you.
No, I think those are good points. I agree with that completely, Ken.
Yeah. Well, it's just about time for us to stop. Does anybody else have a question for Dr. Barry Sarvet? Dr. Sarvet, we hope to have you back in the future. We'll pick a different Friday where we have a bigger crowd for you because this is a creative model that's approaching a public health problem in a very creative way. So I want to thank you, Dr. Sarvet. I think we have the resources that we're going to post to our website. So if you want to listen to the call, our audio isn't usually perfect, but we do the best we can. These calls can be found at www.nami.org, nami.org/askthedoctor. Even though not all of our experts are doctors, we had the woman who's the leader in America in mental health courts last month, for instance, Ginger Lerner-Wren. But it's common that our experts are doctors. So any final parting thoughts, Dr. Sarvet?
No, I don't think so. It's been a nice opportunity. I hope that I was able to articulate the program, and I hope that we can get some good traffic on the website to spread the word.
Great. Thank you, Dr. Sarvet, and have a great day, everybody.
Thank you both.
Thank you.
Bye. Bye, everybody.
Bye-bye.
Take care now.